Hello and welcome to another episode of the Young Tongues podcast. My name is Barbara Fountain and I am the CEO and founder of the Young Tongues, a peer-to-peer support charity for young tongue cancer patients. And I come bearing a magnificent expert today. We will be talking on the topic of financial toxicity, if I get that right at the beginning. There we go. Ashleigh Sharman, welcome to the podcast. It is so lovely to have you. Let me give a quick introduction to everyone who you are. So Ashleigh Sharman is a mixed methods researcher at the University of Sydney and fellow in survivorship, in financial toxicity with the Clinical Oncology Society of Australia. Her areas of interest include investigation financial burden and supportive care needs of people affected by cancer through a policy lens. A research affiliate at Comprehensive Cancer Centre's Centre Chris O'Brien Lifehouse. Much of her previous experience has involved exploring the survivorship needs of head and neck cancer survivors and their caregivers. She is managing editor of Health Literacy and Communications Open and an active member of the Multinational Associate of Supportive Care in Cancer. Ashleigh, you're a busy lady.
I am, and I'm so sorry. That's quite a mouthful.
Some tongue twisters in there, but that's nothing I can't handle. But yeah, Ashleigh, it's so great to have you. And I guess let's start at the very beginning for anyone listening who's never heard the term financial toxicity. What's the definition of financial toxicity?
Yeah, so I'm actually going to read you out a definition first. It's very long, so sit back, relax, and then we'll break it down. I think that'll be a little bit easier for us. So if we think of financial toxicity as the negative patient-level impact of the cost of cancer, so it's the combined impact of direct out-of-pocket costs and indirect costs and the changing financial circumstances of an individual and their household due to cancer, its treatment, diagnosis, survivorship and palliation, causing both physical and psychological harms, affecting decisions which can lead to suboptimal cancer outcomes. That may have been the longest definition you have ever heard, but I think let's just break that down together. And, because there's some really important reasons why this concept has this particular name and why we use this term. So I think the first thing to really think about with financial toxicity is that it's at the patient level. So it puts the patient at the center. So you'll hear a lot of news articles or research articles talking about the economic burden of cancer. And a lot of the times that's actually talking about the healthcare perspective. So when we're designing studies, we do really think about whose perspective are we taking here? And a lot of those economic burdens or the things that, it's about what it costs the healthcare system. That's not what this is about. This is about, again, it's the patient level costs. So the next thing that it brings in is that we want to talk about it's the combined impact of direct and indirect costs. Now, those might not be terms you're familiar with. But if we think about direct out-of-pocket costs, what we mean by a direct cost are things that are directly associated with treatment. So that could be your hospitalization costs, your medication costs. The other thing, and what's unique about this definition, is we're really interested in those indirect costs. So indirect costs are things like the time it takes you to travel to treatment, the time you need to take off work. But it's also incorporating things like the lost income that you're going to have over, that survivorship period. So it's taking that into account as well. Another aspect of this definition, and while we're putting the patient at the center, is that it's not just about the individual, it's also about the household and potentially the community. And so what that can also mean is that we're thinking about costs that are incurred by, if it's a child with cancer, their parent, could be a partner, family member, maybe you're living with your sibling, but maybe you're also living in a society where your community is actually actively involved in your day-to-day care. The next aspect we want to think of, so this definition is getting bigger and bigger and bigger, is that it's not just about treatment. So what it takes into account is what we call in research the cancer care continuum. So this is everything from screening to diagnosis, treatment, survivorship, palliative care. It's the whole spectrum. So it's not just looking at, what were those things that you had to pay for while you were having treatment? No. This is much bigger. And finally, the other unique, aspect to this definition, that it is taking into account physical and psychological harms. So we're thinking about things like the effects of mental health. We're also thinking about the effects of you having to make cost-saving choices and how that impacts your care, or whether at some point this is also impacting your choices in care and in treatment going forward. So it's a huge definition. And I think, it's because it wants to really pay tribute to this patient level experience of costs. And I think the other thing I'll finally just mention is the word toxicity. So this term financial toxicity has really kind of come in the last 20 years. And prior to that, we were using terms like, and you'll see this in literature, or you might see this in advocacy reports, things like financial burden, financial hardship, financial distress. And so the reason that this term financial toxicity was coined was specifically for the experience of costs in cancer. And it was really to elevate this concept. So the time we hear about the word toxicity, it's often treatment related. So chemotherapy-induced toxicity or radiation-induced toxicities. And so what it was really doing is saying, hang on a second, these costs of cancer and the impacts that it's having are just as important as the way that we treat, treatment toxicities. And so oncologists, your treating care team should be paying just as much attention. And so there we have it, financial toxicity.
And that's amazing. And I was, for anyone not watching on YouTube and listening, I was nodding furiously because of everything that you're saying, because I'm like, it really hits a nerve for me, the financial toxicity, but also I prefer that term over hardship or burden, because I feel that some of the financial decisions we have to make have such an impact on the future of our lives and also our identity a lot. So, and actually can have just as a grave an impact as some of the side effects, but they're just not quite as at the forefront or as visible, shall we say. So I guess you have what I'm really, really glad about is that you have a specific interest in head and neck cancers. So why do you think people who've experienced head and neck cancer are particularly vulnerable and compared to some other of the cancer groups?
Yeah, absolutely. And look, I think this is definitely one of the things that comes up in financial toxicity, within all researchers, is that, look, anyone, who is diagnosed, affected by cancer can experience financial toxicity. And I think for me, this was really when I was working at Comprehensive Cancer Centre, Chris O'Brien Lifehouse. They're the national leader in head and neck cancer surgery. And it was something that, when you're working in a cancer centre as a researcher, you are interacting with patients and their caregivers all the time, which is such a privilege. And it was something we'd heard anecdotally that patients were describing to us some of the challenges that they had. Now, in particular around reconstruction, jaw reconstruction, within the Australian healthcare system, for example, dental is not part of our Medicare system. So that sits outside. It sits in the private world.
That's globally the case, I would say. So both the States or England, the United Kingdom, don't have dental included in their services.
Yeah. So there's a couple of so really so what we were sort of thinking about is, okay, so we were really talking to patients who are having full or partial jaw reconstruction and starting to understand those jaw reconstruction costs. Also, and your listeners will appreciate this too, Australia is a huge country. And so the experiences of people living in what we term regional, rural or remote areas, they're having to travel to city centres. We do have some schemes. Those schemes are not sufficient enough. And so really what we sort of said was, okay, we're hearing this from patients and caregivers, but what does the research tell us? And really what we sort of sometimes need to know is, okay, where do we want to go with this? And at the time, and I that still is the case with the team, is really looking at some policy change and going, okay, so if we really want to be able to change this system for patients, what do we need? So we're going to need some evidence. And that's where it really started was, okay, and also working very closely with, our main advocacy group here, Head and Neck Cancer Australia, working with their CEO, Nadia Rosen, really closely, working with their consumer advisory group. So it really kind of started in this space. And that really that's the first time I'd ever heard of the word financial toxicity. And actually, when I looked back at some of that work, we'd actually called it financial burden when we first started it, because we were like, okay, here we go, start doing our studies. And I think really what we saw there was, yes, there are things that all people affected by cancer will experience in terms of out-of-pocket costs, indirect and direct costs. But what we really noticed with head and neck was, first of all, dental, B, cosmesis, so that being the external physical changes, again, within the Australian context. Things like, prostheses, external prostheses are not covered under Medicare. They're considered cosmetics. They're considered a cosmetic. So again, you're nodding. Yes. So that was another thing. Again, regional, rural, remote, but also the invasiveness of the surgeries. And then thinking about that element of return to work. And it was something where we thought, is this something that is unique for people with head and neck cancer because of changes to speech or losing their voice altogether? So one of the ways that we had people participate in our study was, doing a qualitative study like we're doing now, having a chat. Not everybody can do that. So it's about making sure that there are other ways that people can participate. So there were a couple of things that we thought, okay, there's a few areas here. And that's where it was really important to kind of capture that experience.
Just for anyone listening, you used the word policy change. So I obviously know what that means. You know what that means. How would you explain to someone who's not familiar with the terms of what policy change is and how we can influence policy, or even what policy is again? So if that was like step back.
So I think, perhaps one of the simplest ways to describe policy is the laws and the schemes or systems in which your government is operating. And so if you think of them, they're, I guess, like a list of rules or requirements that are, and I think the most important thing is to say is that they're mandated. So they're not things that may or may not happen. They're things that will happen, and they're essentially, mandated into a law or into what we call legislation to make sure that they happen. And policy is generally governed by whichever governmental system you are in. But the thing with policy is that it can change just as quickly as your political parties might change. Your policy can change. It does have a fickle nature about it sometimes, in the sense that how we decide how to make policy change, to add something or take something away, is not quite as clear-cut as you or I would expect. You and I might sit here and say, okay, this is the most important thing for people globally with tongue cancer, and this is what should happen. It's not that simple.
Definitely isn't. Having opened that bonnet over the last few years and gone, oh my God, okay.
Yeah,
not easy to fix things.
Exactly. So what we really had to think about was, and it's one of the projects I'm actually working on at the moment with the Clinical Oncology Society of Australia, is thinking about what are the policies or policy levers, and what that means is what are the ways or the mechanisms in which we can change policy that we can use to address financial toxicity. And some of the way to kind of think about, well, what would those things be, might be things like any subsidy schemes that you have. So, for example, in Australia, we have what's called a patient travel assistance scheme. And I just saw, I think today, that Wales will be putting out their own cancer plan. And as part of that, they're going to have a patient travel scheme for children and adolescents and young adults with cancer. So that's one type of policy lever. Another one might be any rebates you get from treatment or medications that are subsidised. It might be things like management plans that your GP might be able to put together for you, or the things that you might, for example, get 5, complementary allied health treatments, things like that. Or maybe it's to do with things like unemployment benefits or return to work benefits. So with all of those kind of government schemes that you can either play with. So one of the things we can do is look at them and say, well, actually, they're not working, we want to change them. Or we might identify a gap and say, so for example, in Australia, there is no external prostheses scheme. That's for anybody. So we have a scheme for breast cancer, for breast reconstruction following breast cancer, and for limb replacement, but we don't have anything else. So we have like a precedent there that we can play with, but we don't have anything. So we want to create new policy in that case.
Amazing. Going back to financial toxicity, I am going to get that right at some point today. When does it actually begin? What did your research show? Is it like at the moment you're diagnosed, or does it start cropping up during treatment, or is it something that starts long after? She says knowing the answer to this, but...
Well, and again, that's a really interesting question. And so I think this is the hardest thing with financial toxicity when we are talking about because we know that cancer is not a homogenous experience, right? Even within a particular diagnosis, it's also not homogenous. But what we find with head and neck specifically is it is in the post-treatment phase, okay? And what we call survivorship. So it's really in that point of which you've stepped outside the hospital system. And all of a sudden, and particularly in head and neck cancer, where we see that what we might want to term a recovery period being much longer than in a lot of other cancers. So in many other cancers, what we're seeing is perhaps a return to work within 6 to 12 months. In head and neck, that is much longer. And there may not be a return to work at all. And so that's where we're really seeing. And unfortunately, we were talking about policy before, some of those schemes, and a lot of the schemes and policies actually aren't geared up for that period. They're very much geared up for you getting getting screened or getting diagnosed, getting treated, and then that's it.
Yeah, completely concur.
Yeah.
Having recently looked in the UK, we were asked to provide some evidence for the personal independence payments. And that, again, as soon as we went through, it was like, this is not geared up, firstly, for people with cancer more generally. But then if you look at the needs of people with head and neck cancer, there was a even bigger unmet need there. So really interesting because that's the interesting thing about policy. The policies are not necessarily made for us. They're made for a big, diverse group of people. So to make a policy relevant for every section of society is very difficult. Nonetheless.
Absolutely. Yeah, and I would just add to that as well. So, a lot of what we have, I guess what you might call social services or social welfare policy in Australia is, yes, it's a lot of the time for people with what we might call with chronic disease or chronic conditions. Now, cancer is a chronic disease, but the way in which you may be assessed and your eligibility criteria for a lot of these schemes is that you need to have that particular diagnosis at that time. Now, you may have gone through treatment and you now have a clinician saying, well, you don't have cancer anymore, so therefore you're actually not eligible. And so it's really, and you're nodding again, so it's really this survivorship period that is also the eligibility issue. So you're dealing with these it's effects of. And we know that this definition takes into account. But a lot of these services and schemes say, well, you don't have it anymore, so therefore you're not eligible.
And absolutely. And also in terms of us reporting, when we have to fill out these really long, complicated forms, and it asks you to grade your pain or your abilities of different abilities, ability to speak, fatigue, mental health, all of these things. And they're not the same every single day. So how do you judge it? And quite often the advice is given, put down what your worst day is like. But I guess, and I'll talk from my own experience here, not for the community, but I personally was always petrified of being seen as some sort of benefit scrounger, because that's what that's what the media kind of teaches us, is that people on benefits shouldn't be on benefits, all of that like negativity bias. And then it's like, but I do need these benefits to help me to be a functioning human. But some days I am a very functioning human, but on other days I can't put my clothes on. And not having a way to measure that is really difficult. Anyhow, I'm going to have to get off my soapbox now and come back into the room. And we were talking about costs, and I want to shine a light on all the hidden costs. And I would like to think that most people listening will probably know them, but sometimes there might be a cost that you didn't even think is related to your cancer unless you kind of think about it. But in your research, what were the kind of hidden costs that you found were on the long list of things?
Yeah, so I think the hidden is probably one thing, and then unanticipated, or I think so. So the main thing when people were sort of talking to us in the research, these were in qualitative studies where we're sort of just chatting as we are now. Parking was a huge one. A lot of people
Universally,
I know, right?
Parking's an issue.
I think And I think it's still, even though people had heard anecdotally from others that they still thought that, well, if I'm being treated for cancer in this hospital, why am I paying for my parking? And so things like parking, obviously fuel cost, travel, accommodation, they're those typical ones. And then I think when we really think about that survivorship period, it's those smaller costs that add up over time. So it was things like mouthwash, mouth gels, different toothpaste. I have to buy a blender and now I have to buy different foods. Or I have to buy feed, I have to buy thickener, I have to buy different protein drinks. And while the outlay initially was small, it's that compounding over time. So this is not something just for just a couple of months. This is something that you are going to have to be doing for a very, very long time. Sometimes it was things to do with skin creams, external skin issues, also. And then so I think those were those like sort of smaller little things that people thought, oh, and because they're just, maybe, well, I shouldn't say just, but as I said, it's $15, $20 here and there. It wasn't until they actually came and spoke to us and some people had come to the study, and tallied everything up and said, oh, I've got a long list. Do you want to see the list of all the things that I've come up with? And then I think really because getting through treatment is one thing. And thinking about how long am I going to have to take off work? And it really was that income scenario. I will say that in a lot of our work, the average age of participant has been around 55 to 65. So the experiences of people in that, what we might call life stage, was more around things like delaying retirement or a partner having to come out of retirement and partner dynamics changing because of the level of work that's taking place. But I think, as we were sort of saying before, in a younger cohort, that could mean delaying entering the workforce altogether. So I think that workforce piece is really, really important, and that earning potential and just that uncertainty around how you're actually going to navigate work. And I think that was perhaps the most hidden because it's also the most unknown. And we also interviewed clinicians in our study because we wanted to get a sense of what they understood the challenges to be. And that was the thing that they all touched on, was that they couldn't actually give their patients a definitive date of when they can go back to work. And so that really sort of became the biggest clincher.
Yeah, and I think there's also, just to add to that list in terms of a younger audience, things that we see from the discussions as well, there is this big unknown, especially if you were in a career like you were a teacher that requires a lot of speaking. Now you're no longer to speak for 6 hours a day, so you have to do a career change. The cost of retraining, finding a new employer that's willing to take you on with your medical history. Yes, we know there's laws in place, but let's be honest, there's also a reality check here. And then on top of that, potential promotions that we didn't get because we had the time off. And the thing I'm becoming more and more familiar with, so now I'm transitioning from my 30s in my 40s, and I'm suddenly starting to think more long term, the impact on my pension, the impact on my financial security in terms of my savings, when everyone's savings kind of get depleted, but not being able to rebuild those savings, and then what impact that will have later in life. Touch wood, cancer doesn't come back, but what will those 5 years that kind of got taken out, what impact will that have on me when I want to retire, when I'm in my late 60s, 70s and 80s? So, and I think those are the things that are incredibly hard to measure because there's so much uncertainty, because we just don't know what promotion would have come our way or what opportunities would have come our way.
Absolutely. And there is an economic term for that. It's things like opportunity cost of not, and in Australia it's the same. We have superannuation and you will have not had that. And then we also know even, I guess, within that, the layers of socioeconomic advantage or disadvantage, whether you are a part of what we call in Australia, priority population group that is also going to have significant equity issues even within this context of financial toxicity, right? So there's multiple layers again of how we address this. And I think that, yeah, absolutely. And going back to the research, this is, again, one of the hardest things to, and thinking about policy evidence, they're the hardest things to actually capture. I think one of the reasons why there are so many studies about, the healthcare, the burden of cancer, the costs to the healthcare system is it's very easy to measure. Everything that we do in healthcare has a line item or has a number attached to it, but it's a lot. There's a lot more difficulties around, even if I was to say to you and, create a study where I'm going to get you to track all of your individual costs, every single thing for the next year, that's quite difficult. So I think that's the other level of when we're trying to advocate for these issues and we think about, what evidence do we have? A lot of it does rely quite heavily on patient testimony or advocacy work where we try as best we can to estimate some of these costs. But like you said, the opportunity loss, the opportunity cost of these things is very hard to actually estimate.
Absolutely. And we kind of already delved into the subject because I wanted to look at it through the lens of a young patient, young tongue cancer patient or young head and neck cancer patient. And we kind of touched on it on that. And one of the stories that really sticks with me, and I think this is where, you have individual patient stories versus data, so difficult to mesh them up. But it was actually, we were having a discussion about dating. So not really about financial impact, but it very quickly became clear that financial toxicity was having a huge impact on young people wanting to date after cancer. And a young man said to me, in written form, he said, the thing that you don't understand is because of the financial impact of my cancer, I've had to move house. So I've had to move into a neighborhood that isn't comparable to my previous neighborhood. I don't have the social mobility to meet the type of people that I would connect with because I live in a completely different place. I've had to move outside of the city. I can't drive anymore. There's barely any buses. And then he said, also, I would love to buy a girl a drink, but I can't even afford that. And how do I invite someone on a date or do something when I have to choose between feeding myself or so? And the end result was this person basically is living in isolation, being extremely lonely because they can't even go beyond their front door because they feel like I'm just going to be disappointed because it's not accessible to me. And again, how do you translate that into data? Because it doesn't have to be like that, right? So when you were doing your research, what were the kind of greatest financial risk factors to young adults that you were, well, I know you said 55, or maybe we'll have to apply this more. What do you think could be the greatest risk factors to younger adults?
Yeah, so we did have, and as you were sort of talking, I'm sort of thinking back now to all of the people who participated in the study. So we interviewed over 50 people. And without kind of obviously, giving too much information about their personal stories, we did have one young woman who was a music teacher. And I remember she taught woodwind instruments and I just went, oh my gosh, yes. And I think one of the things we know is that really when it comes to financial toxicity, and I might talk about it from a strengths-based perspective, I might talk about what are the protective factors that we know about. And one of the things is working, right? So we know that if you are already working, and, again, this isn't legislative, but, if you have an understanding employer, that you are much less at risk of financial toxicity. Now, the difficult thing if we're talking about especially adolescents, young adults, so if we're thinking of anyone in the age between kind of 15 and 35, 15 and 40, 45. So sometimes in that case, if we think about employment, the risk is that you actually never will enter the workforce at the time at which you were expecting. So we've also had education being delayed. So again, as you sort of mentioned, everything's being delayed. Your earning potential is then being delayed. Your chance to contribute to pension superannuation schemes is therefore delayed. So that's sort of the first thing. So we know employment status is a protective factor. We also know that if you are living in your own home that you own is a protective factor. Again, if we think about adolescents and young adults, the reality of that being the case is very low. So in that case, it's protective. There's a protective factor where you are living with family. Now, I don't know how many young people really want to be living with their family at that life stage, right? So this is when we go back to life stage. This is a life stage of independence, of really getting to know who you are. And so we know that if there is the availability for you to live at home or live with a family member, then yes, that is protective against the, I guess we want to think about the cost aspect of financial toxicity. But remember, and even as you were just saying, there's the psychological aspect of financial toxicity. So that might not be as great for your mental well-being. Okay. So the other thing as well that we think about is really in terms of how long your recovery period is and those things that are going to help you, I guess, in your recovery. What we know is obviously with people with head and neck cancer who have full jaw reconstructions, they are requiring a lot of physiotherapy, a lot of allied health appointments, speech pathologists. We love them, but there's a lot of appointments. And so what we were hearing is that in these more, I guess, aggressive cases with very, in-depth and complicated surgeries, they were having to cut back on those appointments because they were having to make a choice, right? Am I going to eat this week or am I going to do that extra physio appointment, which I think I can not have to do, or I might not go see my dentist, or I might change my nutrition a little bit. So
I was going to say that the dentist is it's a very hot topic, and we have people who are cutting down on how often they'll see a hygienist or a dentist or not see them at all because they can't afford it.
Absolutely. And so in Australia, the recommendation for your average Joe on the street is every 6 months go and see your dentist. Okay. And then all of a sudden you are told then you've gone through treatment and now you're told, well, actually you're going to have to see a dentist more often and for the rest of your life, especially if you've had radiation to the head area, so especially around the jaw. So I think that's something as well that really adds to all of that. And I think also the other risk factors we know, and we kind of mentioned this again, is really around equity. So if you are already of lower socioeconomic status, we know as well, like we have what we actually have very limited data on is in low and middle income countries. So really all this financial toxicity research boomed around the global cost of living crisis. Okay. So because what it did is it took this issue that was already there, and like you were just kind of saying, all of a sudden it just it added an extra layer. And so did COVID. So these sort of things were compounding the issue and really brought it to light. But the majority of work is still being done in high income countries. And we really don't know the experience of this particular term of people living in low and middle income countries. And that's often because the healthcare systems are just trying to deal with that front part of the continuum, trying to deal with diagnosis and treatment. So it's one of those things it's just like every other aspect of equity. It can be, where you're living, how you grew up, education levels. But really with that, if you think about from an adolescent, young adult perspective, it's that delay and it's that stopping or, of all those things that you could be starting to achieve.
Yeah, absolutely. And I whilst you were talking, I've just think there's a new risk factor coming into play as well, which is AI. So we're seeing that at the moment, lots of young tongues, unfortunately, who have to change careers and maybe are now in a more desk-based job, so a more admin-heavy job, is being disproportionately affected by layoffs caused by AI. And it's scarily noticeable in a small community like ours that people are being laid off in not because they had tongue cancer or they're not a good worker, but because their entire department is being laid off because they're now transitioned into those type of jobs where they don't have to speak as much, where it's more kind of data input related. And again, that secondary change is having a huge burden on our community at the moment, and I'm sure that's happening further afield as well. Talking of, so one of the things I'm also interested in is, did you have any evidence from people who were self-employed?
Yes. And so absolutely. And I think this is where, there's no protections, right? So you don't have sick leave, you don't have personal leave, you have none of that to surround you. And I think the other thing that was really interesting is when people were sort of saying, well, maybe I did have income protection insurance and I had all these other things, but then they were notoriously difficult to access. And so that again was quite difficult, assuming that you had these other protections, that they weren't there. And I think then as well, you sort of talked about before this idea of loneliness and being on your own. And the nature just is that there are more of us who are single and who live by ourselves. And yes, we might have strong family and friend connections, but we don't have that typical carer or someone who would identify in that role. And often what we sort of heard was patients saying, well, I'm just getting through step by step. I'm just getting through the diagnosis. I'm just getting through the treatment. I will deal with all of that later. And then not having someone in the background who was helping, fill out those 30-page forms, right? Like to get through all that. And there's actually another term called time toxicity. And that's really around the time that you're taking to do all these things. And in the US, administrative burden is a huge aspect of this as well. And so I think that notion of being a freelancer or having your own business is that it's that very isolating factor, that there's nobody else there to bounce things back off or to sort of support you in that way. And again, then that's a real stop. That's a complete dead stop, right? Like your whole career, there's nothing there. So unless you've got savings, unless you've, perhaps your income protection works, perhaps it doesn't, then yeah, absolutely.
Yeah, I found myself in that situation. So it was a complete stop from one day to the next. The only thing with self-employment where I now see an advantage is being out the other end. I did try employment for a little while and it didn't suit me. Yes. And I do think, again, with referencing the AI and having to sometimes change careers, and I caveat that because it's really only applicable if you have enough energy to do it, which I sometimes do and sometimes don't. But there are opportunities out there for people who can function whilst being self-employed. But it does also come with a higher risk and a higher burden in that sort of sense, because you have to create your own purpose, which I guess somehow Young Tongues has done for me. But it's difficult. So the next question is kind of related. Is kind of what differences did you find between people with permanent employment versus casual work? So especially thinking about the gig economy, because there's a difference between being self-employed, having a business, versus working in the gig economy, which is, delivery drivers, working at multiple restaurants, those kind of jobs. I would assume someone in the gig economy would be at higher risk of financial toxicity to everyone else.
Oh, absolutely. And, we might call it, a financial precarity. So you are already, even we remove the cancer, you are already in a riskier, right? Your financial risk level is higher. I mean, in saying that as well, I think one of the things that we talked about, this hidden or unexpected things that came out, was I think people thought that having a full-time job would be more protective. There was this assumption that, but I have a full-time job and surely workplace law and unions will protect this. But once you run out of leave, you run out of leave. And if you can no longer do your job, you can no longer do your job. And so actually there's another colleague of mine, Laurelie Wishart, who is doing a project at the moment, which is really while I'm looking at the policy levers, she's looking at the workplace case law and reform to really better understand how that's working. And we work with a great advocate in Australia called Sue Woodall. She has a company called Live Work Cancer. And it's really about how also do we educate employers, because there are legal frameworks, but what we actually found through our study was people in our study who had worked somewhere for a long time, they had a very close relationship. So it was these kind of informal advantages or informal systems that their employer was setting up for them because of that relationship. Whereas, in some other cases, once they, no, your leave's done, your sick leave's done, that's it. So I think no one was fully protected, but we're really trying to work with, in the Australian setting in particular, around, well, what's the current state? And not that we would create a cancer return to work policy. We would want a return to work policy for all people with chronic health conditions. But how can we actually, again, coming back to policy, make some of those safeguards set in stone?
Yeah, I completely hear you. And I always, when we hear stories of people and their experiences of return to work and how difficult return to work is and how much more difficult it can be made by an employer who doesn't have the level of empathy or is not willing to create the best working environment for someone who's now different to what they were before, has such a huge impact. And it leads actually nicely into, I really wanted to talk about the emotional burden. And we can start with the employment and returning to work. And I guess I assume you must have heard lots of different scenarios of best case and worst case, where an employer might only do their absolute legal minimum of what they have to do versus people who would really go out of their way to try and keep someone and look after them.
Yeah, absolutely. So, one of our participants, he lost the ability to speak. He was a manager and really thought that his career was over. But, had an incredible employer who said, well, no, you can still communicate via email and there's other ways we can do this. And it was really about educating the whole team. And it really took that, that strengths-based approach to say, well, actually, we're going to use this as an opportunity. Where exactly other people completely never went back, anxiety, depression, senses of rejection, worthlessness, what I've trained for is no longer, that idea of, like you said, of, retraining and that feeling very defeated that I now can't do what I always wanted to do. And that's really difficult. I think for a lot of people, their work is very much tied to their identity, but it's also tied to a sense of providing for family or, especially if you've got dependents as well. Or, as you were saying, it's about being able to plan for the future. And if that's taken away from you, that's incredibly difficult.
Yeah, and I resonate with the loss of identity and the loss of purpose. I think they have such a huge impact on your mental health, and you can just fall apart because you don't know who you are anymore. And to rebuild that and come back from that and shape a new narrative for yourself is so incredibly difficult. So how do you feel financial toxicity affects recovery after treatment?
Yeah, so this is really interesting. So one of the areas where I guess we've been able to really champion this term is in the sense that we do have evidence that it can lead to suboptimal outcomes. Okay. So because this is affecting treatment decision-making, it's also affecting your cost-saving strategies. So you're having to now make choices, and you're not just making a choice between whether I'm going to eat at home or whether I'm going to go to the pub. You're making a very deliberate choice between, like you mentioned, am I going to go for that, dental appointment in the next 6 months, or will I leave it? Or will I leave my next scan? Will I also choose a particular treatment option over another, or will I forego treatment altogether? A number of, the participants in our study in particular really mentioned, particularly around the dental, well, I've only got a couple of teeth missing, I'll just get by. I can chew on one side of my mouth, I'll get by. I won't go out anymore. I won't eat in public because I can't afford that cheek prostheses or that eye, nose, or ear prostheses. And also so not only affecting, I guess, those clinical outcomes, but also affecting, like you sort of mentioned as well, that sense of isolation, social anxiety around not wanting to go out, not wanting to meet new people. We had one grandfather just said he just couldn't see his grandchildren anymore. Just if half of his face was missing, how was he going to have his grandchildren sit on his knee and read them a story? And they're those things where it's that emotional impact is just as important as the clinical outcomes.
Absolutely. And even like purchasing decisions could impact on your everyday health, in terms of the type of food you buy, what detergents, what you used to buy before, even like soaps. Let's be honest. I changed my shampoo because it was too expensive. And yes, very small impact on my hair, but nonetheless, it did have an impact. How do you think, like, the act of worrying about money, because that's, at the forefront in terms of having that elevation of stress, how do you think that can have an impact on people experiencing their treatment, like during treatment or even and after as well?
Yeah, so I guess there's kind of two ideas there. So we do know there is a term called financial anxiety, and it really is about that is, or money worry, what we might want to call it. Exactly. It's thinking about how do I get to that next step? Now, the majority of people in our study said they did not think about money until afterwards. They thought it is something that I will deal with later. I will just, because what am I going to do? And the invoices will come later. So I'm just going to go through everything now and I will deal with it later on. So in the beginning, and also actually I just want to bring up, it was one thing that both our patients, caregivers and clinicians said was they felt financial toxicity, finances was a hard discussion to have. Like, when do we bring it up? Do we talk about it? And there's also a massive power imbalance. If you're sitting there in front of your surgeon and your surgeon's like, oh, it's $20,000. Do you think you can afford this? That's not really the conversation anybody wants to have. So really that financial anxiety was kind of coming in later, once kind of the dust had settled and there really was that understanding of, oh, okay, this isn't just a few out-of-pocket costs around medications and maybe a new toothpaste and things like that. It was really around that. It was the income. And then there's this other idea which is also tied into that is, and you've mentioned this already, just, very subtly, is this fear of cancer recurrence. And so that is another compounding fear. And there is a lot of research in this space, which really then ties into that. And so I think where then this financial anxiety can get to a head is that it can absolutely lead to distress. That's where we get this financial distress term, and depression and helplessness. And how do you then reach out for help? And is that something we also know that, in terms of mental health systems, and there's insufficient access to mental health services as well. And how do we then help someone pull them out of that situation?
That leads on perfectly to the question I had highlighted next is like, do people avoid asking for help because there's a level of embarrassment as well because you may have waited and things have spiraled out of control? What were your findings around that?
Yeah, so I think, globally, I don't know any culture, and please someone write in and tell me if I'm wrong, where talking about money isn't a stigma. Like, we all find money difficult to talk about. And that's the one thing that really came up was no one wanted to admit that they needed any help. But also, so for example, if you think about that, what we call the cancer care continuum. So in the Australian system, a lot of patients are asked about if they need financial assistance when they're diagnosed. Okay. But they're not asked if they need financial assistance. They're asked if they would like to see a social worker. And they don't put the two together. So they see us, they think of a social worker, and one of the quotes that came out from our study was, well, everything's fine at home, I don't need a social worker. But in Australia, it's the social worker that connects you to a lot of the financial services. So they said no. But also remember that they're not worrying about finances till later. And so what we were finding is that people actually weren't being asked at the right time. And so people said, our participants just said, ask me all the time. And so actually it turned out that the people that they were having most of their financial conversations with was their speech pathologists, because they're seeing them every week. They have a much better rapport. And so and they're in that survivorship phase, and that's when those things were being asked. And so that's what we found, that question is being asked way too early. And it's not being asked later on. But then when it gets asked later on, so for example, we have a free service in Australia called the National Debt Helpline. Now, that's quite an intense name. And you might not think that, you're quite at that stage yet. Like, that's quite a loaded title. But also, are they really going to be able to help me? I've got mortgage payments, I'm late on X, Y, and Z. And also, you're out of the system by then. So you're also out of your hospital system, right? So you're out of that social workers who are connected to hospitals. And so you've then got to start to use all those other services. So I think that's, and that's quite difficult. People didn't want to ask family and friends for money. Some people did do crowdfunding, but if they did that much earlier in the piece. They did that much more around their treatment time. Yeah.
Yeah, it's so interesting because so much of it resonates. I was asked if I wanted to apply for PIP, which is the personal independent payment here in the UK, as I was just before I went in for treatment. And my surgeon at the time, he kind of said, "Oh, you'll be back at work within 3 months." So I was like, "Yeah, no, I'm fine." I wasn't. It took me a couple of years. We also had the whole COVID thing in between as well. But I really regretted not applying for it there and then, because I would have applied for it there and then. I would have got it without any questions. But because I waited maybe 6 months and then was like, oh my God, I really need help, I was no longer eligible for it. So, and I really kind of wish someone would have kind of pinched me in the side and said, Barbara, you're applying for this. If you don't need it, you can always cancel it. And I just really felt like, no, I'll be fine. And then suddenly the reality came in, and we relied on family. At some point, my dad was wiring me some money just so we could buy food. And I never would have thought that we would be in that situation ever. And it is a very humbling experience where you'll suddenly find yourself going, hold on a minute, I've done everything right. And now this. I had the double impact with COVID. I was diagnosed in 2019, and there was a self-employment scheme that I would have been eligible for. But because of the timing of my cancer, I was £100 short of the criteria and it would have been it wasn't a huge amount, but it would have been exactly the right amount to just help me get by. And every scheme I applied to, it just didn't tick like one tick box. I was just always, or like I said, 100 quid out from like the annual turnover had to be a certain amount, and there was no leeway. And for me, that was the hardest thing, to a point now where I now don't apply for things because of the rejection factor. The rejection is worse. My GP applied for some special treatment to have hair removed. And I said to please don't, because I can't deal with not getting it. And they were very adamant, no, you'll get this. And I didn't get it. And the mental health impact of not getting it, the whole thing itself wasn't that big a deal, because I was like, I can wait a year and then I can probably pay for it myself. But the rejection of it just was so much worse. And I had another sort of mental health bout of trying to get through this. And I'm sure lots of people listening will empathise with that and feel the same way. Moving on the conversation, I really wanted to also focus a bit on caregivers. And I mentioned, like, my dad wired me some money.
Yeah.
But, like, what impact did you see on the wider family caregivers in terms of the financial impact of trying to support someone with head and neck cancer?
Yeah. Yeah, absolutely. So in our head and neck study, it was the biggest thing was delaying. So obviously because of the age group, just remember, so this is kind of 55, 65, the two biggest things were delaying retirement or coming out of retirement altogether. So they were the two really real biggest changes. What we do have in Australia is we have a lot of great researchers and advocacy groups, for example, Red Kite, who have done a lot of work looking at obviously the parents and the families of children with cancer. And what is, I guess the unique thing in that particular priority population group is that it is not the person with cancer who is applying for these things. It's the parent or the caregiver. And they're not necessarily eligible because they're not the person with cancer. And then they're also facing a lot of work changes as well, and that income earning. But also, I think one of the things, and being a cancer carer myself of family members, it's also the delayed mental health aspect. So I think caregivers are not particularly great at, and that's not, our focus is is caring first, and we'll deal with ourselves later, and we will do everything we can to help. So I think there was a lot of that as well, and some inbuilt pressure to help support as well. And that was what's really important, I think, for every study to really look at caregivers as well. And what is interesting, I think, is from, I guess, going back to a policy and a legislative point of view, is that a number of organisations in Australia are starting to change their caregiver leave. So that's something. So in addition to your personal leave days, your sick leave, you actually now have carers leave, bereavement leave, and these are all things that we can also start to legislate. So at the moment, it's very much an organisation by organisation point of view, but that's something as well that, I'm very lucky working in a university that I've been able to access.
Absolutely. And I just wanted to pick up on this because I don't think we said it explicitly. We've mentioned mental health a lot, but we haven't actually acknowledged that having a phase of poor mental health puts you in a position where you can't necessarily look after your finances, or you're not in a headspace to deal with the numbers. And I experience this regularly. I have me and finance and anxiety seem to be in a triangle dance a lot of the time. And it is, when you are feeling that low and you're depressed or you have anxiety, where you are struggle to even look after yourself in the most basics of feeding, washing, clothing yourselves, to then be expected to deal with complicated household incomes, mortgages, insurances, forms, or even a simple spreadsheet of what's coming in and what's going out. It's a lot. So, and I do sort of, just throughout this conversation, I was thinking more and more, we need to highlight this link between mental health and your ability to look after your financials at the same time, and how they're in competition with each other.
Oh, absolutely.
Yeah. So, Ashleigh, it's so happy to have had you on. This hour has just kind of disappeared. But before we go, I've still got two more topics, and we'll just push through them. So first, I just want to talk about you a little bit and your research, and what motivated you and what drives you to continue this research, because you're obviously very passionate, and we love that. But what led you down this path?
I think for me, it was really going back to those head and neck cancer patients at Chris O'Brien Lifehouse. And so firstly, it was that, it was something that we'd heard, everyone knew about it, and I really realized, hang on a second. Yeah, we can do better. Australia prides itself on its healthcare system, universal healthcare coverage, but there just seemed to be massive equity issues, particularly within particular cancer groups as well, and head and neck obviously being one of them. And I think as well, from a personal perspective, I have a lot of financial anxiety myself. I'm very low risk when it comes to finances. And so I think there's that intrinsic also understanding, like you said, and also someone who is diagnosed with mental health conditions. I get that triangle, Barbara. I'm in that triangle with you. It is. And it's something that, our whole society is very geared up on money and buying houses and being able to look after people and strive. And for me, I sort of really see it as something that also is a hidden aspect of cancer that people don't feel is being listened to as much as other issues.
Yeah, thank you. I just got reminded, I don't know if you're familiar with this chap called Martin Lewis. You are brilliant. His travel, fantastic.
Yes.
Yes, Martin Lewis, what a gem. And I remember we watch his programs a lot and everything. And it's talking about the kind of millennials and youngers. And one of the things he kind of said on his program was like, if you're just one crisis away from financial ruin, and me and my husband looked at each other and said, yeah, we are now. We had the cancer, we survived that. But for a really long time, we're in this risk category where we just needed one more thing to happen to really mess us up for the longer term. Hopefully, I think we're kind of navigating our way out of that. But that financial anxiety that came with it stays. It's just here all the time, constantly worried that we're going to lose out on it. So, yeah. Anyhow. Maybe this is a good transition to my last question, which is about practical advice. So anyone listening to this, including myself, who's living with this, what is kind of the practical things that you feel we can put in place either early on during diagnosis and treatment, but especially in this survivorship era that we find ourselves now?
Yeah, absolutely. I mean, one of the things that I think is really important is, so we know that financial toxicity affects all people with cancer. But what's really important, I think, especially for young tongues and for advocacy groups, so for example, some of the work I do with Head and Neck Cancer Australia is really thinking about, okay, what are the aspects of financial toxicity? What is unique in my community? Okay, and so what are those things that I might need to fight for from a policy point of view? But B, also prepare. So we know knowledge is key, but we also know during diagnosis and treatment, there is information overload. Like you said, maybe I've got anxiety around this issue. I don't want to deal with it. I'll deal with it later. So one of the things I think is really important, but also knowing that someone's going to ask you maybe about your finances early on and you're going to think you're okay. And you're going to be like, oh, I'm fine. Don't worry about it. Yeah. Okay, but no. So what we've been doing with Head and Neck Cancer Australia is putting together like a very simple PDF of all of the different schemes. So I think one of the things that people don't know about is what you do have access to. Now, we have a number of systems. They are imperfect systems. They're not perfect schemes. They're not perfect systems, but they're there. And for the moment, the best thing is to know about them. And like you said, apply early for these things. And unfortunately, sometimes exactly the time burden, the administrative burden, you're going to need somebody to help you. So it may be that one of your carer team, your extended community, maybe there's just one friend who is your admin friend, who is your financial assistance scheme friend, who's going to help you through those particular things. So what we're trying to do and what we're doing with Head and Neck Cancer Australia is putting together a list of all of those schemes. Sometimes there are different schemes in different states and different regions, just so that you know what is available. There are schemes for, for feed, there's schemes for travel and hotel assistance, there's schemes for allied health appointments. So putting all of that information together in one document is really important. I think the other thing as well is that is hard, but thinking about those financial conversations and asking questions. So we all know as well in the beginning, there's like so much information, but there's also not a lot of time for you to ask questions. There's a lot of you being told. And I think that's the other thing as well. And really I guess that's where advocacy groups and community groups really come together, is to help each other out. Because I still probably don't know all of the schemes. But, I went and visited a group, the Brisbane Head and Neck Cancer Group. So shout out to Marty and his amazing group there. And they were telling me things that I didn't know about. So there's just all these hidden things that I think is, and having a list of all those schemes is actually probably one of the best things to do. So it's almost like a checklist, because we can't say to everyone, prepare, talk to your financial advisor, talk to your accountant, make sure you've got this much money in the bank. No, that's not going to work. what we need is to show you what you do have access to, that there is some levels of support. They're not all great. You might not get all of them, but that's really, the best place to start. And really thinking about, the role of advocacy, the role of policy, what's that one thing that, that we've maybe discussed today, or maybe, you'll get comments from your community around what's that one thing that we could really change here. So the thing that we're working on with Head and Neck Cancer Australia, as I mentioned, is external prostheses. So we know the dental, we know that there's not really much what we call political interest or appetite in that right now, but maybe we can move on the external. And we start with that, and then we build from there.
You seem to be in the exact same political place like we are in the UK, because there is no appetite to support dental at all. And it's so frustrating because it seems like the easiest
I know.
Not the easiest thing to fix. Not at all the easiest thing to fix, but it seems to have the thing that would have the greatest impact for our community. But we also kind of have to be a bit strategic and clever about how we're going to go about it. And it might just be a long-term vision and trying to start and building these relationships with MPs, individuals now, so we can hopefully find someone who will who will carry that torch with us, for us in Parliament, because we always need those sponsors and things. But no, totally agree with everything that you said. And in terms of putting together lists, I have thought about that, because we are a global community and we will get there one day. But I think in the short term, whilst we don't have that in place, what I would advise is to not only join the Young Tongues, but also join your local cancer support groups.
Absolutely.
From the services that are provided in your hospital settings to your more regional things, because that's where I learned all my stuff. A shout out to Shine Cancer Support, to Macmillan, and to the Big C Centre. And I know there's Maggie's in the UK as well, and I'm sure there are a lot of equivalents in different countries, in different regions. But it was like a piecemeal. It was finding something out from one person, another thing from the other person. And nobody seems to have a full comprehensive list of what I call...
No, nobody does.
No, nobody does. And I called them the silver linings, because that was the first thing. As soon as I was diagnosed, I said, I'm going to try and find all these silver linings. I did not know that if you had credit card debt, that some credit card providers will just wipe it. Did not know that. Had a friend who did that very successfully, and I was like, wow. So and that's where, again, going back, you mentioned like the national debt advice line. They have that type of knowledge, and even though it seems we need to overcome this hurdle to ask for that help, and these schemes don't have the best of names to make them appealing to contact, it is worth doing so, and doing so early. But yeah, there are so many different small schemes, and we just need to keep sharing that intelligence with each other, so we're all aware. So, Ashleigh, thank you so much. It's been an absolute delight to have you on, and thank you so much for sharing all your knowledge and your research. I will make sure to put links in our show notes, so if people want to go and read your papers, they can. And thank you so much for coming along.
Well, thank you so much for having me. It's been such a pleasure to see you grow Young Tongues. I absolutely love it. So hopefully this will not be the last podcast.
Definitely not. Thank you so much. Have a lovely week.